This UCSD TV program is a presentation of University of California Television. Your support makes UCTV's programming possible. Contribute online at uctv.tv/support. Check out the YouTube original channel UCTV Prime at youtube.com/UCTV Prime. Subscribe today to get new programs every week.
Hi everybody, I'm Dr. David Granite, and welcome to Health Matters. Well, we all worry about it, we all see it, we look at our skin and we notice there's a change in color and we notice there's something that might be growing. Could it be something? Is it something? Is it melanoma, that word that none of us like to hear? What is melanoma? How do we treat it? But really, what's new? And what are the new changes that are going on, and how do those changes occur? This is a robust topic that we're going to have today, and we have with us a real expert, Dr. Bill Waxman. Welcome, Bill. Thank you for joining us on the show.
Thank you for having me, David.
Dr. Waxman is an associate professor here at UC San Diego and a staff physician at the Veterans Hospital and an oncologist by trade. I sort of set this up as a melanoma show, but it's really a cool, new, almost science fiction, fun show as well, because what you're doing is really neat. But to start with, I want to start with the core of what is skin cancer, what is melanoma, and how we deal with it today, and how we're going to deal with it maybe one day very soon.
Well, as you know, there are a lot of different types of skin cancer, and what everybody really worries about is melanoma. Many of the other types of skin cancer are rather slow growing. You have basal cell cancers and squamous cell cancers. I've actually had basal cells, and they can be on your skin for not just months, but even years and not cause significant problems. But melanoma, once it invades and dives deep down beneath the surface layer of the skin, can cause a lot of problems, including metastatic disease, and in a significant number of patients that have invasive disease, you can actually have an outcome that's fatal.
So in preparing for the show, I come across a number that says about 130,000 new cases a year in the United States.
And that includes both invasive and early stage in situ melanoma.
And in some estimates, about 9,000 people a year who are dying from this. So the trick is to catch it early. Why? Why is catching it early so important?
Because early stage melanoma is curable.
Wait, say that again, because that's a word that we don't use that often in medicine. It's curable.
Early stage melanoma is curable. It doesn't mean that you won't get a second melanoma somewhere else, but that initial melanoma, if it's caught in the earliest stage, typically in an area that's in situ, meaning it hasn't begun to dive deep or invade, or even in the earliest stages of invasion, if that melanoma is excised with an adequate border of skin, is curable.
And that means, like I said when we opened the show, people see a mole, they see a change in the color of their skin, and they're wondering whether they should run and get it checked, and how often they should get it checked. So they go to a doctor, and they might go to their internist to take a look at it. They might go to a dermatologist, and they say, do I have to worry? How do we currently look at changes in skin pigmentation or moles and know whether or not to worry?
Well, the training that we all have gotten in medical school is to use some visual criteria, which are called A, B, C, D, and E, that look at the nature of the lesion. So just simple visual examination, how big the lesion is, whether it's changing, whether the border is regular or irregular, whether it's bleeding. All of this goes into the mix of whether something reaches a level of suspicion that whatever that pigmented lesion is a melanoma. In addition, dermatologists now are using some optical tools. The simplest one that many in the United States and in Europe and elsewhere use is called a dermatoscope. And it's sort of a magnifying lens. They put a solution on the skin and they can hold the dermatoscope down and they can pick up other nuances that they wouldn't see without that optical device. And there are other newer optical devices that are pretty sophisticated and only being used in a few places in the United States and elsewhere around the world. But even those do have a, although they're sensitive in detecting the melanoma, the specificity is not optimal. And when I say not optimal, another device for which I won't go into details about, although the sensitivity was 98%, meaning 98 out of 100 melanomas were being detected, the specificity, meaning how many of the lesions that were biopsied that this optical device said were melanoma, only about 10% turned out to be melanoma. That's better than what's now occurring, 1 out of 20, 1 out of 30. If you just use...
So there's a couple of things that I want to make sure that we're clear about is that you're talking about when somebody says this could be a melanoma, whether they're using the old-fashioned sort of look at it, using these optical devices which are being used to enhance the capability of a dermatologist to identify whether or not it's like a melanoma, that sometimes they're melanomas and sometimes they're not. Right. So when your dermatologist says, I'm a little worried, the predictive value of I'm a little worried, whether it's using these devices to look at it or to the standard way that we've done it now, you're saying that it's the positive predictive value of that worry when they go on to really do some more definitive testing. 1 out of 30 of those people that you're worried about?
And again, it depends on your dermatologist.
Sure.
There are dermatologists who are pretty good at what they do, who will be 1 out of 20 or 1 out of 30. And then there are what I'll call super subspecialists, people that are experts in pigmented lesions. And they may get down as good as 1 out of 3 or even 1 out of 6, meaning for every 6 biopsies, 1 would be a melanoma, or if they're 1 out of 3, for every 3 biopsies, 1 would be a melanoma.
And that's the next step, right? I mean, it's a biopsy. You have to, somebody has to have a procedure of some sort where there's some pain involved and cutting involved and bleeding or whatever it is that they go through. And then a pathologist has to look at that under slides and be able to make the definitive diagnosis. And so there's this whole process that's involved of trying to identify whether or not it's truly a melanoma. And the nightmare is being wrong.
Correct.
Telling somebody you're okay when you're not.
Exactly.
So if the error that we think of as doctors is, I don't want to miss anybody. And so if I'm going to make a mistake, it's going to be the mistake of, we'll take out some normal. We're going to remove some normal moles. And I can live with that because I don't want to miss the other. But as a goal, because there's some $300 to $500 million a year spent on all this, is to be more efficient, to reduce the pain and discomfort of the patient, and to be accurate and quick about it, to make sure we're as good as we can be. Because even the pathologist looking in the laboratory, some 10% of the slides are really easy, and some of them are really hard to tell the difference.
And the pathologist isn't looking at the entire biopsy. They're looking at only what they call representative sections of that biopsy. So they may only look at 5 sections of an entire biopsy to make a decision. So there can be, in that case, if you're not looking at the entire thing, a sampling error that can occur, and you might miss something that would otherwise be picked up.
Well, so that's sort of where we are today. And our goal, especially as people on faculty at a university, is how do we make things better? What can we do better? And one of the reasons I wanted you to come on today was because you have something that's really cool that you've worked on that may be like the people try to use the optical device. It may be a new, better way to try and identify whether or not this is truly something to be worried about or it's something that you can relax about. And I'd like you to tell us a little bit about what you've been working on.
Okay. So my background, besides being a clinical hematologist and oncologist, is that I work in genomics, looking at levels of gene expression. And we, for all practical purposes, asked a question whether there are differences in the gene expression in skin that overlie a lesion. And the trick was, how do you sample the lesion in a way that's not going to be a problem for the patient? And it all occurred by chance.
Yeah, I want to hear, this is such a great story. So we're going to segue for a minute and just tell us how it happened, because I'm not sure everybody understands that sometimes research is a creative moment, that the right person at the right moment connects things that wouldn't have otherwise connected. And that's somewhat chance, but somewhat chance favors the prepared mind. So somewhat being prepared.
So I had been asking myself, besides looking at an actual tumor specimen for a biomarker, could I find something in blood? Could I find something in urine? And it wasn't necessarily aimed at melanoma, but in general. Where are tumor markers? How do I pick these up? And I was thinking, well, maybe skin is a good place to sample, and how would we go about that? And I was chatting with a neighbor who lived 3 or 4 doors away from me. This is in Carmel Valley. And he looked at me and his eyes sort of widened, and it turned out he was the head of a small biotech company based here in San Diego in La Jolla that was working on a tape-based method of sampling skin and looking at genomic signatures that are in cells that are collected off the tape.
Now, come on, what are the odds of that? Right? I mean, 4 doors down from you.
Exactly.
Just incredible.
And literally within 72 hours of that meeting, where we were just kibitzing in the middle of the street, I found myself meeting with him and another member of the board of this company called DermTech International. And work started, and over a period of time, I ended up as a member of their scientific advisory board. And then we started talking about melanoma as a target. And the key was, could we tell a difference between a pigmented lesion that was melanoma and a pigmented lesion that wasn't melanoma? A simple process.
Is it or isn't it?
Is it or isn't it?
Which is an incredible concept, that this accidental meeting turns into what may be something that is available for all of us, that makes a difference. And fortuitously, I'm glad that you guys lived on the same block. So you said tape-based. Now that sounds almost too easy.
Well, it's not quite as easy as getting a roll of Scotch tape out of your drawer, pulling it out, putting it on your skin, and then scraping off stuff from that tape. DermTech has a proprietary adhesive tape shown in this little,
I know you brought some with you,
container. And what you'll see is that there are discs. The discs are about the size, at least the adhesive surface, about the size of a nickel. And there are 4 tapes. Each tape, as I say, has a type of adhesive that they know what's in it. And
I gather you know too, probably. So.
Well, I think by trial and error, they picked up several different types of tape. And what normally is the case is we use a standard alcohol swab.
Do it on me. Just we'll show how easy this is.
And I would normally wipe off the skin. I'd be wearing gloves.
Yeah. So we'll take an adhesive. This is so straightforward. So we wipe off the skin.
And while we talk, we just want it to air dry, so the tape sticks. And we don't like people to have used moisturizer or other lotions on their skin.
I'm not a big moisturizer guy.
And
I should
normally, if there was a pigmented lesion that we were suspicious about, let's make believe there's one right here.
Yes.
So now the skin's dry, and you just put the tape down, and let's say that this is over the pigmented lesion. We just rub the tape around while holding the skin taut, peel it off, and the material that's on the tape, and we would then be able to remove, and there's a reagent that we use in the test tube to remove the material. We isolate ribonucleic acid, or RNA, and then we can analyze a number of genes. And actually, the discovery research that we did used a microarray from Affymetrix that looked at 54,000 targets simultaneously, where we can look at 54,000 gene products.
Yeah, the human brain can't do that. I mean, you have to have an array and a computer.
And we could look at the level of expression of each gene. We knew that a lesion, because everybody who was in the study that we performed, and the study collected melanomas from around 15 or 16 different sites from around the United States, because we needed a fair number of melanomas.
Sure.
And we, after collecting the sample, the patient would get a standard of care biopsy. The biopsy was read by 2 pathologists, dermatopathologists, and then the data were split into 2 sets. One set would be what's termed a training set. The other set of data was a testing set. And we had 37 melanomas in the training set, 37 non-melanomas in the training set. And we were able to identify a 17-gene, what's termed classifier, which is really a biomarker composed of those 17 genes. Each gene, the level of expression was somewhat different, but by comparing the melanomas to the non-melanomas, right, and those 17 genes picked up every single melanoma, and in the training set, around 90–95% of the non-melanomas were also correct. And now the proof of the pudding is actually testing it and using 89 additional samples. We were able to look at melanomas and non-melanomas that weren't part of that training set. Again, all the melanomas were called correctly. So the test was 100% sensitive.
Yep.
And it turned out that 88% of the non-melanomas were called correctly, so it's 88% specific. And that's quite above the somewhere, right, where in the community it's about 3.5 to 4% specificity, and in the hands of an expert, maybe 20 to 30% specificity. And this isn't meant to diagnose a melanoma, it's meant to direct whether a melanoma should be biopsied. So what's going on now from this sort of work is that the company is taking the discovery data, and that was done, as I mentioned, on a microarray, which is pretty expensive, and moving the clinical, the assay onto what would be a clinical platform using quantitative PCR, or polymerase chain reaction assays, so the cost will be lower.
Sure, and makes it reasonable to use in a clinical setting.
Exactly. And they're in that process at the moment.
With tape.
With tape.
I'm loving it. This is awesome. The thing that hit me too is I was talking to my wife about doing the show with you, and I told her what we were talking about, and she said, "Oh, that reminds me, I'm supposed to go to a dermatologist and get checked." And it had been 2 or 3 years, and she's light colored with some moles, and she goes, "Oh, I hate going." And I thought, why? And she said, "Oh, you know, I don't want to have biopsies." And so, there are people who avoid going to get checked because it's annoying and they don't want to have the biopsies, et cetera, which is obviously a huge negative because they're going to get missed or found later. So the barrier to entry for an examination to know whether or not you're going to need a biopsy now, if there are less biopsies being done, that makes it a lot more palatable to go get checked if you think it's unlikely that I'm going to get a biopsy if I don't need it.
And also what's intended is that we'll not provide a yes or no back to a physician. We're actually going to provide what's termed a risk score. So based on the current distribution of melanomas and non-melanomas, we've divided a risk category up into 0 to 5, where 0, 1, and 2 contain no melanomas. You may have a melanoma at a risk score of 3, and the likelihood that it's a melanoma goes up at risk scores 4 and 5. It goes up dramatically.
Got it. Now, the couple things I want to make sure that we touch on today, because I think they're really valuable. Could you have done this without an industry partner?
No. And simply put.
Yeah, but so here you are, you're faculty at a medical school, and yet you couldn't have accomplished this without an industry partner. And this is a really important issue because the industry partnering, especially here in biotech world of San Diego, is so valuable. Why was it so important to you in this setting?
Well, for a couple of reasons. Normally the way I get money for my research is you write a grant, you submit a grant, and you hope that it goes through the review process favorably. And that process generally takes, if it's a short process, it takes 6 months. But the vast majority of grants take much longer than that, even if it's favorably reviewed the first time around. In general, most people end up submitting a second time, so now you're talking maybe a year and a half till it comes to fruition. The other facet with this sort of research is that it's really outside the box type research. So in a way, it's a crazy idea. Why should I be able to detect melanoma from the surface of the skin? The reality is melanoma is deeper down in what's called the epidermis and doesn't typically get in to the topmost layer of the skin, the stratum corneum. If I had submitted a grant asking whether I could detect melanoma on the basis of a genomic signature
on the
from
surface of
the
the
stratum
skin.
corneum, I think anybody with a substantial amount of knowledge about melanoma would say, I doubt this could be done. And that, even if they thought it was a pretty novel idea, that shadow of a doubt often gives you a unfundable score. So I could have been running around in circles for years. Often the biotech companies, they see the possibility of this innovation as a plus, and they're willing to move forward and start small, and if things are working well in a way with milestones, you're allowed to move forward, and that's exactly what occurred.
And in a much faster fashion than you could have
Exactly.
in the typical way to do it. There's going to be money saved to the system with this, less biopsies, et cetera, in an era where we have to talk about cost of health care, so that's fabulous. But it doesn't just show up in an office. You have to go through all this rigorous testing, and eventually the Food and Drug Administration has to say, okay, this can go out there. And so even though you can get to this point where you are relatively quickly, then there's a moment in time where the brakes come on and the FDA gets involved and you have to go through another process.
Or other regulatory agencies in Europe and in Australia. One of the issues here is we're, as I mentioned, moving this on to a clinical platform with quantitative PCR. And after we get everything in place and all the procedures down pat and we're all happy with everything, we now have to undertake a validation study where we enroll patients, and we estimate the first validation study will look at about 100 melanomas, and figuring that for every melanoma that we get, we're going to be getting anywhere from 5 to 20 non-melanomas. When you start cranking those numbers through, you're looking at really a couple thousand patients.
Yep.
A couple thousand patients in a small study is a lot to do. And hopefully we'll be able to collect that information in about 6 months. This will all be done in a blinded fashion where the laboratories performing the assay will not know what the biopsy results will be. And there'll be a third party who knows what's going on. And then there's another interesting facet that I didn't mention. So on the original study, we actually went back and said, well, 13 of our biopsies were false positives, meaning
they showed up like there was melanoma, but they weren't.
They showed up and they weren't by 2 different pathologists. And as I mentioned, typically the pathologists look at representative sections. So we asked them to serial section, to look at everything in the entire biopsy. And one of the 13 actually turned out to have an invasive melanoma. So it's not the pathologist's fault. From a cost standpoint, they did exactly what they were supposed to do. So this
you
technique—
found one that was missed.
Right. We picked up one that was missed, but when you start expanding this not just to 100 biopsies, to tens of thousands of biopsies, we may actually be able to pick up more melanoma. That still has to be proven, but we believe that that's a possibility.
Well, and you can imagine a scenario where if someone's positive with the tape test, the pathologist is going to look a little bit longer and a little bit harder to make sure that they've looked through the whole specimen.
And there are some people who work specifically on melanoma genomics, and they've done this for quite some time, that believe that what we may be seeing is the emergence of a melanoma signature that is in advance of the change in morphology.
You're seeing it before the pathologist.
Exactly. So that a positive signature may actually mean that even though you can't see it under the microscope, over time what you're seeing will become a melanoma.
So which one is the gold standard?
Well, good question.
We're going to find out over time, right?
Hopefully.
Now, the exciting thing for me, in addition to obviously what you're doing and the creative process that we've talked about, the partnering with industry, is that there's going to be other applications for this. The skin's a giant organ, and you guys have talked about psoriasis, other types of cancers, and other applications for this, because
even
you're getting...
So even on melanoma, we then said, we know we're picking up early stage melanoma as well as invasive melanoma in this initial assay. What if we just ask questions about the samples that are melanoma? And we presented data this past spring that we could actually separate the invasive melanomas from the in situ melanomas.
I love it. So now we're getting really down to the nitty-gritty, right, in a way that at first I'm guessing you probably thought you wouldn't do, but now you can.
What we're now asking is whether we can use this to help the dermatologist and the oncologist stage a melanoma once it's been biopsied and we know depth of invasion. So this may be an adjunct to the current staging procedures that are being performed.
You look like you're having fun.
I am.
This is what you were born to do, to create new ways of approaching diseases, to try and advance the technology. How much fun is it to be in an academic center, partnering with industry, and being able to use these creative juices?
Well, I think this is what most of the people at UCSD really live for.
Well said. I agree. I think that's why we're all here. And I can't thank you enough for being here and for all the great work that you're doing. We're going to cycle back in a couple of years, and you're going to tell us all the new advances and all the different diseases that we'll do. But my guess is by then, people will already be more familiar with this because they may have seen it in their own doctor's office. Thank you so much for joining us on our television show.
You're welcome.
You've been listening to Dr. Bill Waxman talk to you about advances in medical science. Specifically, we talked about melanoma, but what I want you to pay attention to is how sometimes creativity works in medicine, how it takes a very creative person to put together two things at the right moment sometimes to make it work. And then it's followed by hard work. The studies that have to be done, the hard work that has to be done to prove that these creative ideas work. All of that is what goes on in an academic medical center. And we have one of the great ones here in San Diego, so it's really a pleasure to always have these kinds of experts on with us. Knowledge is power. The more you know, the better your health is. I'm Dr. David Granite, and we'll see you again next time right here on Health Matters.